hand, because most other people have used all your data and your statistics and told you about a lot of the problems. But I want to give you kind of a much broader overview about the challenge we have with wounds. You've heard about the costs. You've heard about that 8.3 billion we spend and the number of patients with wounds. You've heard a little bit about the impact on patients, whether that's pain, whether that's that leakage. We also have to remember not everybody's old who has a leg ulcer. Some people have a job. That job may be in a business. It may be as a mother, a father, a grandparent caring for a child. Because I'm sure there are some of you in this room like me, who part of your job is as a grandparent caring for a child on a regular business, on a regular basis. So we need to think about how that impacts on society as a whole. But I'm here to talk about how it impacts on the NHS. And we've heard some data presented, and one of the things I will put forward to you is how challenging that data capture is and how inaccurate some of that data is. Because we know across the NHS, one of the things we struggle to do is get accurate data. And we burden our clinicians by additional data capture because our digital solutions do not work for us. We have massive databases in the NHS that capture information direct from the patient's electronic record when it works well. And that's the big point. It often doesn't work well. It's fragmented, it's challenging, and the language used is not the language of clinicians. So we need to look at how we can use that and use those systems better so that we actually know not only the burden of wounds, but where the burden is in the system. You've heard that the majority of lower limb wounds are in the community, but we know that a large percent of the cost happens when they go in hospital. So if a patient with a leg ulcer goes into hospital, particularly if it's because of the leg ulcer, they will get their bandage taken off. They're usually there because they've got an infection or some other problem. The nurses in acute systems are not trained to manage leg ulcers. It's not in their language. And they take it off because they're worried about pressure ulcers. They then have lots of antibiotics. We have to worry about antimicrobial stewardship. Not all our GPs are as clued up about leg ulcers, and they see the smell, see the slough, see the leakage, and presume infection and prescribe inappropriately. But we don't actually know where the biggest burden is because our systems don't follow the patients through. Patients with leg ulcers going to primary care is fraught with challenges. Trudy mentioned that 10-minute appointment. I was on a social media system this morning where the local TVN was saying she had a real challenge because in her ICS, the practice nurses were now saying it was not their job to look after patients with leg ulcers. It was not their job to wash that patient's leg. That was a social care problem. This is a patient who needs care. So for the NHS, we have this huge amount of fragmentation. We have siloed working. And that all causes a significant problem for the patient as they bounce from pillar to post. And our lower limb patients, like all our chronic wound patients, are cared for across the whole health economy. We repeat their data capture. We lose their information. We've got no consistency in the treatments that are applied to them. And that is a real problem. We are very short-termist. So you heard from our two surgeons earlier talking about that primary prevention. When you look at the guest data, and that guest data has been cited, 41% of the wounds are lower limb wounds. Not all venous leg ulcers, but 41% are lower leg wounds. As I said, my background's pressure ulcers. I'm really proud. Only 7% of those wounds are pressure ulcers. And do you know why? Because we focus on prevention. We are terrible at healing pressure ulcers. We have no data on how to heal pressure ulcers. We need to get better at that. But in order to reduce burden, we need to prevent what we can, and those that occur, heal quickly and prevent the recurrence. And it's only if we do those three things can we improve that burden. And in the NHS, we are not good at those. You may be in an area with a good vascular team and be very fortunate with your treatment, but what have you got in terms of prevention? We also have a system where in venous leg ulcers, I think one of the reasons why we focus on treatment is because we have good evidence. So we know that if you get that patient a good assessment, a diagnosis and intercompression, your chance of healing them is really good. But it's those steps that are all really important. We have less good evidence about prevention and we need to think about that. I think the other challenge for us is that patients with lower limb wounds often don't present to us. If you look at patients with venous leg ulcers, they will tell you, oh, my auntie had one, my grandma had one, everybody else in my family has got one. So there's an expectation that they don't heal because they never did. So they self-manage, not the shared care Trudy was describing. They just don't come to see us, so they don't get the right treatment. And by the time they do come, it's only because they're in a real challenging state. So that public acceptance of this is just something that happens as you get older really needs to be challenged. We need a really strong health promotion message about what you can do to help prevent yourself. If you're starting to have really swollen legs, do something about it. As you get older, moisturise your skin, really simple things. But I think really importantly, we need to see our ICSs taking ownership of these patients that move through their system and understand that at every step of the ICS, that care needs to be coordinated. We need to get better data to support what is happening to our patients, but that shouldn't be at the cost of clinical care. It should be data collected at the point of care delivery. So in conclusion, I think we have some really good evidence in treatment of leg ulcers, but what we don't have is consistent and coherent application of that. And some of that is because of the lack of services, and some of that is because the lack of a drive to understand how to best apply that across the whole healthcare journey. Thank you.